Okay, hello dear guys. So now we continue our set of lectures about genetics, and last time we stopped in general principles of genetic disorders, and we had some examples of genetic disorders. We discussed what is the Marfan syndrome, and also what is familial hypercholesterolemia. So now we'll continue our set of lecture, our examples with the cystic fibrosis. What is the cystic fibrosis? So let's start with definition. So cystic fibrosis is a disorder of epithelial ion transport affecting fluid secretion in exocrine glands and the epithelial linings of the respiratory, gastrointestinal, and reproductive tract. So you remember that on the surface of each cell we have sodium channels, yeah, which allow sodium pass in, and you remember that sodium concentration inside the cell and sodium concentration inside the cell that facilitates the osmotic pressure inside the cell. And fulfillment of water inside the cell and the transport of water inside the cell is totally depends on sodium transport. And that's why, and here we'll discuss what's the pathology of cystic fibrosis and how it makes their alterations, and what is the pathology of this cystic fibrosis. So is the point of our next discussion. So, ion transport defects lead to abnormally viscid mucous secretions that block the airways and the pancreatic ducts, which in turn are responsible for the two most important clinical manifestations: recurrent and chronic pulmonary infections and pancreatic insufficiency. So these symptoms you have to keep in mind. So respiratory tract infections, recurrent respiratory tract infections, and pancreatic.
Sir, please share your screen.
Yeah.
Please
Okay,
share
okay,
screen.
okay. Thank you that you mentioned me. So now 1 minute. Yeah, I didn't show it to you. So now you see, yeah. So this is cystic fibrosis. So once again, it's epithelial ion transport affecting fluid secretion, exocrine glands, and the epithelial linings of the respiratory, gastrointestinal, and reproductive tracts. So this definition must be understood. And you see, abnormally viscid mucous secretion that blocks the airways and pancreatic ducts. So you understand so why it happens. So just what the pathogenesis we'll discuss right now, but just keep in mind that all the mucus which is produced, it will be extremely desiccated, extremely viscous. And if it's very viscous, so just remember, yeah, respiratory tract. That we in respiratory tract we have a feature of mucociliary transport. Mucociliary transport is a transport of cilia. So when cilia push the mucus out towards the upper part of the respiratory tract. That's the main feature of respiratory tract. That in trachea and bronchi and bronchioles we have ciliated epithelia which move the mucus upside, and they are lined for specific. So one so for specific properties of this vicinity. Yeah, so viscosity must be in a proper way. So if it's too viscous, we can't remove it with the usual mucociliary clearance. Without cilia, we can't remove it. So when cilia, if cilia possibly, if cilia is possible to remove, it removes. But if it's not, if it's impossible, so it will stuck there. And so if we talk about respiratory tract, then you know that in air we have a lot of germs and bacteria, and which very easily can settle in this mucus, and it causes chronic infection diseases in respiratory tract. And that's why you have to keep it in mind. And when patient come to you and says that every time, so every little cold they have a very hard cough, and it happens a few times a year, and always so. And he have to check himself for tuberculosis, yeah, TB, because you see he was always coughing, and all the relatives they ask him to do something with his health. And that might be that you should keep in mind that it might be the pathology of this pathology, this genetic pathology. It is also a type of disease which is not which is not happened in so which is not we have no manifestation of it in early childhood. Sometimes it happens in early childhood, but usually it happens. So its manifestation happens in a later period. Okay, and what is the and about the pancreatic ducts? You remember that pancreas in pancreas ducts we have a lot of mucus secretion. We need to smear mucus to normal transport of pancreatic juice into the duodenum. And this mucus also preserves the ducts of pancreatic glands preserved from self-digestion. You remember the pancreatic juice is composed of lipases, amylases, and proteases. Yeah, so like trypsin, chymotrypsin, and others. And you understand that we are composed of lipids, we are composed of carbohydrates, we are composed of proteins. And if this pancreatic juice will be in direct contact to cells there, so they can destroy our pancreatic ducts. And sometimes in some defects, like this defect or other defects, it happens, and pancreas undergoes a self-digestion. And of course, in digestive tract, we will discuss this in much more details. But anyway, now we have now you have to know it. Okay, in addition, exocrine sweat glands are structurally normal and remain so throughout the course of the disease. A high level of sodium chloride in the sweat is consistent and characteristic biochemical abnormality. So that's why sometimes in detection of the disease, in diagnosis of the disease, we check the sodium chloride level in sweat. If your sweat is too salty, so it might be we have some changes. You have cystic fibrosis. So let's along with other manifestations, of course. At the same time, it must be remembered that cystic fibrosis can present with a bewilderingly variable set of clinical findings. So we have different set of findings. Okay, an incidence of 1 in 2,500 live births in the United States. So in the carrier frequency in the United States is 1 in 20. So it's a carrier. Yeah, you mean I understand what is a carrier. So it's a carrier of this gene. So Caucasians, yes, I mean European descendant people, and they are. And lower in African Americans, so here's the American book. That's why they pay attention to American American epidemiology. Okay, and then it means that 1 in 20. So if they create a pair, if they create a family, so we have a 25% chance that in this family of these carriers will happen will appear the children with cystic fibrosis. So that's why it's very common. Cystic fibrosis follows simple autosomal recessive transmission. Also, even heterozygous carriers have a predisposition toward pulmonary and pancreatic disease at higher rates than the general population. So we discussed it before, yeah, that we have in biology, you used to remember that we have recessive disorders. They have no manifestations. We have no signs of this. No signs of this. No signs of this disease before if it's recessive. But actually here it's not very right. Mendel was not very right in this position, because we have so you remember the how it happens, yeah, that this protein, which protein we'll discuss a little later, so is encoded by 2 chromosomes. Yeah, and if it's present in both chromosomes, you're a healthy person. If it's absent in both chromosomes, you will suffer with cystic fibrosis. But if you are a carrier of this gene, so you have a little depressed amount of this sodium channel, so chlorine channel, so which is suffered, and that's might lead to some little disturbances in your respiratory tract. and pancreatic juice secretion. So it is not clinically significant, so it's usually we treat it like just usual changes, so not genetical changes, but actually predisposition, so some some predisposition to this disease we have in case of carrying of this gene, but you don't know that you're a carrier. Okay, pathogenesis. So let's discuss what is pathogenesis. Primary defects in cystic fibrosis is reduced production or abnormal function of an epithelial chloride channel protein encoded by the CF transmembrane conductance regulator gene. So you see we have chloride channels, a chloride channel protein. So, and you remember all channels are proteins, and if it's a protein, we have a gene about it. So, a disruptive mutation in the CFTR renders the epithelial membranes relatively impermeable to chloride ions. Relatively impermeable, so it doesn't mean that chloride is prohibited inside the cell, but anyway, so when chloride doesn't come inside the cell, it causes desiccation of cell. Okay, impact of this defect on transport function is tissue specific. The major function of the CFTR protein is in the sweat gland ducts is to reabsorb luminal chloride ions and augment sodium reabsorption through the epithelial sodium channel. So, in the sweat ducts, loss of CFTR function leads to decreased reabsorption of sodium chloride and production of hypertonic sweat. So that's why I said you before that sweat will be much salter than it present in a normal person. In contrast to sweat glands, CFTR in the respiratory and intestinal epithelium is one of the most important avenues for active luminal secretion of chloride. At this site, CFTR mutations result in loss or reduction of chloride secretion into the lumen. So active luminal sodium absorption through E sodium channels also is decreased, and both of these ion channels increase passive water absorption from the lumen, lowering the water content of the surface fluid layer coating mucosal cells. So what happens here? So let's show it here. So sodium can be absorbed inside the cell, so along with the chlorine, and only they increase the if we have increased concentration of sodium chloride inside the cell, so there will be normal secretion of a normal mucus. But if there will be there around it, so secretion of this will be desiccated with a little amount of water, and that's why so cell cannot absorb water from the blood and can produce proper mucus. So that's a point. So here, so this is normal mucus. You see sodium enters inside, chlorine goes outside, and water absorbed. So from airway, so it's a normal process. But in a way of chlorine channel injury, so chlorine cannot be released. So sodium in larger amounts enter inside, and water intake, reabsorption of water happens much more abundant, and that's why mucus will be dehydrated. So you see, it's normal process to absorb the water. It's normal water to reabsorb water. We have to keep our body. We have to keep our water inside the cell. But if chlorine is not released from the cell, so this water here osmotic pressure inside the cell will be increased, and sodium retention will be increased, and water retention also will be increased inside the cell. That causes in one case it causes swelling of this mucosa, and secondly it causes dehydration of mucus here in airway. So, no difference in the salt concentration on the surface fluid or layer coating the respiratory and intestinal mucosal cells in normal person and in those with CF. So, salt concentration is similar. Instead, respiratory and intestinal complications in CF in cystic fibrosis seem to stem from dehydration of surface fluid layer. So only surface fluid layer is desiccated. So it doesn't mean that entire mucus will be desiccated. Entire mucus will be dehydrated. So only the surface fluid layer is dehydrated, and that's enough, because on surface we have cilia, which helps to remove this mucus. That's why in the lungs, this dehydration leads to defective mucociliary action and the accumulation of concentrated viscid secretions that obstruct the air passages and predispose to recurrent pulmonary infections. That's what I started with. So you see, so if sodium cannot be released, so we can't maintain the normal fluidity or so viscosity of mucus, and it cannot be removed by cilia, which is present in lungs. And it leads to what? So if it can be removed outside, so it can be removed towards the bronchi and trachea, it will be stuck inside the lungs, and sometimes even descend down due to breathing movements. Yeah, we just inhale back this viscid mucus. So under the so during the gravitation, so on the influence of gravitation, so we have so this mucus will be descend down. And you remember that. If mucus present is so near the borders, it doesn't obstruct the blood, doesn't obstruct the air pathways. But if it's present in bronchioles, for example, where orifice is very small, so it can totally obstruct one bronchiole. And of course, this part of lungs is not working. And later in the next lectures, we will discuss environmental diseases. And in case of smoking, so mechanism is almost similar mechanism. So pathogenesis is different, but the mechanism of infections is similar. So, and these patients like smokers, yeah, so they have disorders similar to smokers, and that's why if you see the patient who doesn't smoke but has the same complications as smokers, so you can say that, yeah, might be he has a cystic fibrosis. Okay. Okay, in addition to chloride, CFTR also regulates secretion of bicarbonate ions. In fact, certain CFTR variants manifest only with abnormal bicarbonate transport, while chloride ion transport is largely preserved. So in some types of these gene disorders, in some types of disorders, chloride transport is okay, but bicarbonate is unable to work, and that affects, of course, pancreas. So you remember physiologically in the stomach we have acidic environment. pH is about two pH. It's a very acidic environment due to hydrochloric acid in it. Yeah, and pepsin, which is present in stomach, is normally destroys the proteins, yeah, until the oligoproteins, and they only can pass in the duodenum. And you understand that in duodenum flux a very acidic environment, very acidic milieu enters here. And how our body handles with it? First of all, I remind you histology is that in duodenum we have a Brunner's glands, which are all present in the wall of duodenum, so which is responsible for production of bicarbonate, so in large amount of bicarbonate, and the same do the ducts of pancreas. Ducts of pancreas, they produce not only mucus, but they also secrete bicarbonate to neutralize the acidic environment in acidic milieu in duodenum, because duodenum is not acceptable for acid, so they can't handle the acid. And in these patients, we would see the pancreatic insufficiency. Due to the pancreatic insufficiency, so one of manifestations will be ulceration of duodenum sometimes. So that's one of action. Okay. So since CFTR gene was cloned in 1989, more than 1,800 disease-causing mutations have been identified. So we found different gene mutations, and you see 1,800 disease-causing mutations are found. So you see, it's not one mutation. There are a lot of different types of mutation. And of course, clinical manifestation will be different. So you see, it's a protein, yeah, and protein might be it is working, but might be not working properly. So might be don't work at all. So might be work only in this way, but not in another way. So and that's why clinical. So we have no common manifestation of this disease. So somewhere it's more or less active. Okay. So mechanically, they may result in a reduced quantity of functional CFTR that reaches the cell surface, or reduced function of CFTR that reaches the cell surface. As we shall see, these differences impact on the development of treatment strategies. And they can also be classified as severe or mild depending on the clinical phenotype, as I said you before. Okay, without delving deeper, so let's talk about pancreatic abnormalities. Which pancreatic abnormalities we have to see? Pancreatic abnormalities are present in 85 to 90% of patients. In the milder cases, there may be only accumulations of mucus on the small ducts with some dilation of the exocrine glands. In more advanced cases, usually seen in older children or adolescents, the ducts are totally plugged, causing atrophy of the exocrine glands and progressive fibrosis. So you see, you remember, yeah. So here we see these changes. So here we see a duct is empty. Duct is empty, so here we have normal mucus secretion has. But here you see this is the duct, and inside the duct we see this hyaline-like mucus here. So it's very concentrated mucus present inside, and it will cause the stuck in pancreas secretion. Okay, 1 minute. I'll answer to call. Okay, here you see the mild changes. Yeah, so mild changes. So we have a mucus, so thick mucus inside, but lumen is opened. But in some cases, in some ducts, like here, like here in smaller ducts, we have a very abundant mucus, so very abundant and concentrated mucus inside the ducts, and it can be considered as a cystic fibrosis manifestation. Okay, then another so morphological changes. Okay, so which changes we can see in clinical manifestations? Sweat glands, increased sweat chloride concentration. We can find sinuses. Sinuses will be there, so they will cause sinusitis. So you see that in the nasal cavity we have mucus secreting glands, and they so as we name as sputum, yeah. So sputum is produced by sinuses, and so not only sinuses and the nasal cavity. And if sputum became very concentrated, so in case of infection or even without infection, it can occupy the meatus of the sinuses into the nasal cavity, and that's why it causes the how isolation of this mucus in nasal cavity, isolation of mucus in sinuses, and of course it promotes the infection there. So that's why sinusitis are very common. Okay, in lungs we have inflammation. So it causes chronic inflammatory diseases. And later we'll discuss it. But most of you already heard about it. It's COPD, chronic obstructive pulmonary disease, will evolve there. It is usually a disease of smokers. But in this case, even if you don't smoke, so this disease might happen. And if this patient smokes, so yeah, of course, its disease is much more evident and much more manifested. And sometimes here you have pseudomonas infection. So what is infection disease? So what is pseudomonas infection? You will discuss in microbiology, but pay attention that very common pseudomonas infection. And then we have bronchiectasis. So bronchiectasis is almost always related to this cystic fibrosis. So bronchiectasis it happens due to coughing. So because a lot of mucus and thick mucus produced, you have to cough a lot, and due to coughing, so pressure inside the bronchi and bronchioles is increased, and that causes the dilation of this, and along with infection, along with inflammation there, so it causes dilation of it, and then fibrosis, dilation and fibrosis, healing by fibrosis happen because it's chronic inflammation there. Yeah, and that's why gradually during the life, from the small orifice of bronchi and bronchioles, it increase the size of space of bronchi and bronchioles, and this condition is known as bronchiectasis, ectasia of bronchs. And it has in the respiratory tract infection, in respiratory tract pathology, we'll discuss in details what is bronchiectasis, but it might be you heard about it. Okay, liver. What happens in liver? So some in later in old patients, it might cause a cirrhosis. So usually it's not happen individually, just with the liver, but sometimes the liver has cirrhosis. So reason is similar. Bile which is produced by liver, so became very thick. Became very concentrated, and due to this, it cannot release properly by the by hepatic ducts and by biliary tract, and that's why it stuck inside the liver and causes chronic inflammation due to congestion of bile inside, and that's why it causes also attempts at healing. So it will be fibrosis of the liver, and fibrosis of liver is known as cirrhosis. Then pancreas. As we said, yeah, in pancreas will be exocrine dysfunction. So first of all, amount of juice, pancreatic juice released is will be not sufficient, and that's why we can see the effects of digestive tract. So because you know that main digestive enzymes are present in pancreas, and if they can't reach the duodenum, so of course we will have malabsorption, malnutrition in this patient, and no proper digestion happens in digestive tract, and that's why it causes polyphycalia and also formation. Also, okay, all the malabsorption features will be there. Pancreatitis, of course, it's acute. So usually acute or chronic pancreatitis will be there. So it's inflammation of pancreas due to congestion of pancreatic juice inside, and self-digestion of by enzymes. So usually, okay, might be you remember from physiology that in pancreas produced. So once again, three. Um, Not three enzymes, but three groups of enzymes. Yeah, so lipases, amylases, and proteases. And when they stuck there, so they usually produced in inactive form. Inactive form, but later this inactive form might be so might be activated directly inside the pancreas, and it causes the cell destruction. And actually, along with the decreased secretion of sodium bicarbonate inside the pancreas, so it causes much commonly causes the activation of these enzymes inside the pancreas, and these enzymes will destroy this pancreas. And you remember pancreatitis is associated with a fat necrosis. Yeah, so when pancreatitis happens, this pancreas is destroyed, and fat which is present in amentum bursa. So directly here it's present behind the stomach. Yeah, and this fat of amentum bursa gets lipased. So I mean enzyme lipase destroys it, and then calcium attached to this, and then we have this chalky appearance of fat. So this is pancreatic. This pancreas. This pancreatitis, this is fat necrosis, which happened due to pancreatitis. I just remind you the topic of necrosis. Then diabetes. You remember that in pancreas we have islets of Langerhans, and due to chronic inflammation in pancreas, these islets of Langerhans also get suffered, and here we have a here might be formed the diabetes mellitus, and so it might be classified as a first type insulin-dependent diabetes mellitus because it appeared in early age. Okay, intestine, so it neonatal obstruction, so it's called meconium ileus. So what is this? You will discuss it in pediatric pathology. And we have distal obstruction, so also due to desiccation of mucus. So because here in digestive tract, so produced mucus, so very abundant mucus, and this mucus helps to slight migration of fecal masses. But if mucus is very thick, so this migration is so slight motion of this fecal masses is interrupted, and due to this, so we also have distal obstruction of fecal masses. So it leads to, so in easy words, it's constipation. Yeah. And in male reproductive tract, so in male reproductive tract, it causes azoospermia, infertility, and bilateral obstruction of vas deferens. So sperm is formed properly in a testis, but vas deferens, in vas deferens, when it transport of sperm cells goes into the semen, so it might be obstructed. Sometimes it's obstructed because we have no proper motility here, and no proper passing of cells into the prostate and semi-vesicles and prostate, and that's why in ejaculate we can find no sperm, and this is known as azoospermia. And even if they reach the prostate, so their development is interrupted due to decreased amount of water around, and that's why they might be quite inactive, and that's why in male infertility is also a very common complication of this disease. Okay, pulmonary changes are the most serious complication of this disease. These changes stem from obstruction of the air passages. Okay, I explained this in details. So it will be like chronic inflammation and formation of bronchiectasis. So might be here, yeah, if I'm not mistaken, it's a bronchiectasis. So yeah, you see here it's a dilated bronchial tract. So present in a cross section of in a longitudinal section of trachea and bronchi. So here we see the very dilated bronchi, and due to dilation of bronchi, so it collection of sputum, infected sputum happens inside, and due to this, patient always have a chronic inflammation in one area, chronic site of chronic infectious disease in one area. Okay, this is what is a clinical. Okay, clinically, we discuss what is clinically will be there. So it depends on which type of CFTR is injured. So which CFTR mutation happens. So that's why we have to in every of these cases, in case of bronchiectasis, in case of recurrent respiratory diseases, especially in childhood and even in adulthood. So in cases of infertility, male's infertility, we have to check your patient for this disease. So okay. Then we'll switch to another disease which is known as phenylketonuria. Phenylketonuria is a disease. It's also mutation. It's the disease caused by mutation of phenylalanine hydroxylase. Phenylalanine hydroxylase. So normally phenylalanine is ingested by the baby from the milk of mother, and in biochemistry might be discussed, might be not, but it's you have to remember that phenylalanine is a precursor for sorry. So it's a precursor of tyrosine. So okay, 1 minute. Okay, as I said, yeah. So tyrosine is very important. One of the very important amino acids in our body, and but what happens when phenylalanine hydroxylase is present? But to increase the amount of phenylalanine is also is very bad. Okay, let's talk about epidemiology first of all. It affects 1 in 10,000 live-born white infants, and there are several variants of this disease. The most common form, referred to as classic phenylketonuria, is common in persons of Scandinavian descent and is distinctly uncommon in African American and Jewish populations. Okay, so homozygotes with autosomal recessive disorder, so it's autosomal recessive disorder, classically have a severe lack of PAH. So PAH is phenylalanine hydroxylase, remind you, leading to hyperphenylalaninemia and PKU. So what's PKU? Phenylketonuria. Affected infants are normal at birth, but within a few weeks exhibit a rising plasma phenylalanine level, which impairs brain development. So increased phenylalanine level lesions the proper development of brain, and it later causes infancy disease, which is retardation. Yes, so it will mental retardation of patient. Usually by 6 months of life, severe mental retardation becomes all too evident. Less than 4% of untreated phenylketonic children have intelligence quotients greater than 60. So that's why untreated patients are they became retarded, mentally retarded. About one-third of these children are never able to walk, and two-thirds cannot talk. Seizures, other neurological abnormalities, decreased pigmentation of hair and skin, and eczema often accompany the mental retardation in untreated children. So it seems like this disease causes the retardation. But nowadays we have a treatment against it. So how treatment against it happens? First of all, we need a so okay, here it's explained how it's transportation, filling hydroxylase, cause the formation of tyrosine and water. Uh, but if not, it's okay. Never mind. Uh, so no, don't remember this biochemical process. But anyway, so we have if we have this enzyme doesn't work, so this phenylalanine will be preserved inside the body and causes retardation. But how to treat it? So how we can treat it actually? We can treat it with easier with mm, prevention of phenylalanine entering into the body. So now we have artificial milk. So we create the milk without phenylalanine inside, and just in the first 5 years, we feed person with dietary without phenylalanine, and then after 5 years, another enzyme takes function of this phenylalanine hydroxylase and forms the tyrosine by another pathway. And that's why a patient with this disease, so in adult, if he was properly treated um, before the adulthood, so you can't recognize them. You can see that he's a little different. Absolutely no. So that's why phenylketonuria is treatable disease right now, and this is one of the best examples of medicine advances. And we used to think before that phenylketonuria is untreatable disease, and your children with phenylketonuria is fated to be retarded. But actually now, due to genetic treatment, pathogenetic treatment, we can save these patients from being retarded. Okay, then galactosemia. So galactosemia is an autosomal recessive disorder of galactose metabolism resulting from a mutation in the gene encoding the enzyme galactose 1 phosphate uridyltransferase. So it causes so here is in this galactosemia it causes the accumulation of galactose 1 phosphate and it's metabolized in tissues. So in easier words, the clinical features may include jaundice, liver damage, cataracts, neural damage, vomiting, diarrhea, Escherichia coli sepsis. Diet restrictions of galactose can prevent at least some of the more severe complications. Okay, this much rare disease, so that's why I pass it easier. So then lysosomal storage diseases. Lysosomal storage disease. So you remember that lysosome is also known as um, lysosome is also known as suicidal back inside the cell, and if and lysosome control the process of autophagy, so internal cell degradation. So when cell degradation happens, lysosomes are actively digest our own cell components, and but in case of pathology of this lysosome, we have these diseases. So here you see what happens. Complex substrate. So when complex substrate is ingested by a cell, we have so normal lysosome degradation happens and then destroyed in a small compounds, and the small compounds are released outside. And small diffusible end products are released into the cytoplasm. That's normal ingestion by the cell. But in case of lysosomal enzyme deficiency or lysosomal storage diseases, so these products will be absorbed by lysosomes, but they are stored inside because the enzymes are not properly degraded, and it causes, first of all, defective fusion of autophagosome with lysosome, yeah, and defective degradation of intracellular organelles, which cause a collection of autosome, collection of degraded organelle structures. So it causes accumulation of toxic proteins, induction, and it causes induction of cell damage. So due to toxic proteins collected inside. So for example, like there will be collection of misfolded proteins, yeah, and it can cause cell death. In other ways, in other ways that due to defective degradation of intracellular organelles, it causes accumulation of aberrant mitochondria, so senescent mitochondria, and this mitochondria cannot provide proper functioning. And you remember, damaged mitochondria, they can generate free radicals, which also, from another hand, it causes cell death. So that's the essence of lysosome storage diseases. So it has autosomal recessive transmission. It's a much rare condition. So that's okay. In clinic, you will discuss it in more details. So usually it happens so we have a Gaucher syndrome, for example. It's in nervous system. In nervous system it happens, and also it takes part in Alzheimer's disease. So Parkinson disease, Gaucher disease, and Niemann-Pick disease and Alzheimer's disease is believed that they are caused by these lysosome storage diseases. Okay. And you see, first of all, nervous system is affected by this, because in nervous system we have to replace all organelles all the time, because the nervous system play a very important role in normal activity of the body. Okay, then next one is a Tay-Sachs disease. So this Tay-Sachs disease is very common, or is very common for Jewish population. So only in Ashkenazi Jews. So Ashkenazi Jews, they're German. So they're Jews which appeared in German countries before. So in medieval period, they had they were present in Germany, and that's and these Ashkenazi Jews, they have, as I said, autosomal recessive disorders are very common in this population, and one of these diseases, which is specifically present only there, is the Tay-Sachs disease. So you see, it's gangliosidosis. It's gangliosidosis. So gangliosides are it's lipids which are present in especially in brain. We have it to facilitate the normal enveloping of nerve fibers inside the brain. But if we have in case of Tay-Sachs disease, it causes gangliosidosis. It results of deficiency of one of the lysosome enzymes that catabolize their glycolipids. So it's also a type of lysosome impairment, lysosome storage disease. Okay, and enzyme known as hexosaminidase. So it causes a collection of glycogens. Glycogens, yeah, and due to this, so normal functioning of the normal function of nervous system is impossible. Okay, also we have Niemann-Pick types A and B, so we don't delve deeper, so just main idea. So related entities characterized by primary deficiency of acid sphingomyelinase and the resultant accumulation of sphingomyelin. So and they have almost so they also typical for Ashkenazi Jews, so which are which also affect the brain. Yeah, also affects the brain, and then it causes deposition of sphingomyelin inside the around the nerves, around the nerve fibers. I mean. So it has a lipid vacuolation inside. So for example, here is a nerve, and inside here is a nerve, and this myelin sheath, yeah, and inside we have a lot of lipids. This is sphingomyelin. Okay, and then another Gaucher disease. So this Gaucher disease, it's in quotes glucocerebrosidase. Glucocerebrosidase it results in deficiency of this enzyme, leads to accumulation of glucocerebroside and intermediate in glycolipid metabolism in the mononuclear phagocytic cells. So, okay, Niemann-Pick disease is also common in Ashkenazi Jews, and also has neurologic signs and symptoms we have type 1, type 2, type 3, so you don't have to remember it by heart. Okay, then let's switch to this mucopolysaccharidosis. They are characterized by defective degradation and excessive storage of mucopolysaccharides in various tissues. The mucopolysaccharidosis is a part of extracellular matrix and are synthesized by connective tissue fibroblasts. Most mucopolysaccharides is secreted, but a certain fraction is degraded within lysosome through a catabolic pathway involving multiple enzymes. Okay, mucopolysaccharidosis is a secretion of mucopolysaccharides. As name implies, it's a mucus. Yeah, so increased mucus production in which accumulated in tissues. So, for example, it's a dermatan sulfate, heparan sulfate, keratan sulfate, and chondroitin sulfate sometimes. Okay, which manifestations will be there? Hepatosplenomegaly, skeletal deformities, lesion of heart valves, subendothelial arterial deposits, particularly in the coronary arteries, and lesion in the brain are features that are seen in all of the MPCs, mucopolysaccharidosis. So in easy words, so without delving deeper, so mucopolysaccharides is a component of extracellular matrix, and if we overproduct them, so it impairs the normal functioning. So that's why, without delving deeper in pathogenesis of the disease, you can understand that how this disease is changing. And this is all of them are okay. All of them are lysosome storage diseases. And then let's talk about glycogen storage diseases. Glycogen storage disease is inherited deficiency of any one of the enzymes involved in glycogen synthesis or degradation, can result in excessive accumulation of glycogen or some abnormal form of glycogen in various tissues. So we have a hepatic type. So hepatic type of glycogenosis. So when a liver can collect this, it can collect the glycogen but cannot use this glycogen in a function. And it causes enlargement of the liver due to storage of glycogen and hypoglycemia. So it's because it fails to glucose production, and this disease is known as von Gierke syndrome, von Gierke disease for Gierke. So it's once again von, not von Gierke, it's von. It's because of German scientist. So, and it's caused because of lack of glucose 6-phosphatase. And if you remember the physiology, so glucose 6-phosphatase is the most important enzyme in deposition of glucose in case of glycogen. Okay, and myopathic type. So you remember that in skeletal muscles we have striated muscles, we have storages of glycogen. So in case of extreme needs of glucose, so these striated muscles, they are able to produce glycogen. But here with these enzymes are injured, so also glycogen is deposited there, but it can be used by this cells. It's known as McArdle disease, or also known type 5 glycogenosis. Okay, type 2 glycogenosis, it's POMP disease. It's caused by deficiency of lysosomal acid maltase and is associated with deposition of glycogen in virtually every organ, but cardiomegaly is the most prominent. So in this case, striated muscle of heart is deposited with the glycogen, and of course, so it causes heart failure. Okay. Then disease is caused by mutation in genes encoding proteins that regulate cell growth, and of course it's discussed in tumors. So we discussed it in previous topics. Then complex multigenic disorders. Complex multigenic disorders. So it's these disorders we discussed before. So it's these disorders, they have abnormally a large amount of genes enclosed in it. So and we have a cluster of this disease, and they are not shared by Mendelian rules. So one example. So which examples? We have so far some examples are cytogenetic disorders. Um, okay. So let's talk about cytogenetic disorder. Yeah, so let's talk about cytogenetic disorder. It's about chromosome disorder. So when we have a normal number of chromosomes, so we have numeric abnormalities. Numeric abnormalities is when instead of 46 chromosomes, uh, we have, for example, 46. We have 47 or 45 chromosomes. Let's discuss these examples. So a normal amount, it's known as euploid chromosome number. Chromosome numbers such as 3n and 4n is known as polyploid. So it's in humans. It's very rare. It's a polyploid cell. We have few polyploid cells in our body. So, for example, megakaryocytes. Yeah, they are polyploid cells because in one cell it contains more than 46 chromosomes. It's multiplied, yes, so number of chromosomes is located in one cell, so it's exception actually. But like a rule, so we have we have 46 chromosomes. Any number that is not an exact multiple of n is called aneuploid. So when we have less than 46 or more than 46, it's aneuploidia. The chief cause of aneuploidy is a non-disjunction of a homologous pair of chromosomes. So here, let's remind you the process of mitosis. So 1 minute. So here, so okay, let's talk about structural abnormalities of chromosomes in the chromosomes. They might be translocations. So translocations, when one part of a chromosome is translocated to another chromosome, and you see, for example, this and this part are joined in information of fusion, in central fusion, and this and some part of chromosome is lost during the mitosis or in meiosis. So due to this, it can be translocations. So balanced reciprocal translocation. So when a similar amount of genes are changed between themselves. So it's normally present like in crossing over process. But when we have Robertsonian changes, so when we have unequal chromosomes formation after this, and it's more related to pathology. So we have isochromosomes. So isochromosomes, when short hand of these chromosomes are detached from the long hands. So that's also like formation of reciprocal chromosomes. Deletion. So some part of chromosome may be deleted during the cell division during the mitosis process, and also causes the shrinkage of chromosome, and some genes are lost in this condition. Then inversions. So when some part of chromosome is inversed in another position. So like here we have paracentric, and paracentric, which is present in one hand of the chromosome, and pericentric, when exchange happens in between through the centromere. Okay, and then a formation of ring chromosomes happens. So when some fragments are deleted and they form the ring, chromosome is ringed. Of course, it's unable to work. Okay, these chromosome changes are not very typical. Okay, They are typical in, especially these changes are very commonly found in the case of tumor. In case of tumor, because of mitotic. So this all these changes are prevented by telomeres. So with the proper amount of telomeres, and also if we have at least one of these genetic abnormalities, so usually our cells undergo the process of apoptosis. But uh, but in case of suppression of apoptotic genes, it might cause it might cause a formation of new cells. Okay. Then general features of chromosomal disorders, they may be associated with absence, deletion, absence, or excess or abnormal rearrangements of chromosomes. So it's a deletion, monosomy, trisomy, and translocations. In general, loss of chromosomal material produces more severe defects than does a gain of chromosomal material. Excess chromosomal material may result from a complete chromosome, as in trisomy, or from part of a chromosome, as a Robertsonian translocation. Imbalances of sex chromosomes, excess or loss, are tolerated much better than are similar imbalances of autosomes. Okay, and now we'll discuss it later. Sex chromosomal disorders often produce subtle abnormalities, sometimes not detected at birth. Infertility, a common manifestation, cannot be diagnosed until adolescence. In most cases, chromosomal disorders result from the de novo changes. For example, in parents are normal, and risk of recurrence in siblings is low. The translocation form of Down syndrome exhibits an uncommon but important exception to this principle. Okay, let's talk about cytogenic disorders involving autosomes. So first of all, it's Down syndrome. It's trisomy of 21st pair of chromosome. The most discussable type of disease, because this syndrome, because of what? Because actually it's very common, and their number of chromosome is 47. So it happens because of meiotic non-disjunction. So when meiosis happened, this 21st pair of chromosomes, they're short hands of 21st chromosome, they're just fused, and then instead of one chromosome in one ovary, ovum, or in the sperm, so it will be a 46. So it will be two 21 chromosomes. And that's why with the joining with the sperm with the 21 chromosome, so only one 21 chromosome, it appears that in the one cell appear so three 21st chromosomes in one cell. So very common. It's very common. It's incidence in 1,550 live births. And actually births, so a lot of them get aborted. So because some signs of Down syndrome can be measured in early early natal period. In early pregnancy, we can check some hormonal changes. You will discuss it in pediatric diseases, I guess. And then we can do the abortion. In this case, it's a medical prescription for abortion. So even in your country, I guess. So I know that it's restricted in your country, so it's prohibited. But in this condition, so in case of Down syndrome, so it's very easy to do abortion. I hope, at least. Okay, but why don't we have, for example, absence of 46 or 21st chromosome? So if we have no 21st chromosome, so this child will not evolve, and it will be just miscarriage. So it always causes a miscarriage. Okay, so which signs of Down syndrome we have? So first of all, mental retardation. That's the first thing you remember. There's epicantic folds and flat facial profile. So that's why in the European countries they named this disease as a mongoloid disease. So it's mongoloids. They named as mongoloids because epicanthus is present. Yeah, epicantic fold which is typical for mongoloid descendant people. So from Asian descendant people. And flat facial profile is also typical for Asian people, so like Chinese or Korean people or Japanese people, yeah. And that's why facial profile sometimes resembles the Asian profile, and that's why in Mongolian, in later 19th century, English people, they named this Mongolian disease. So we have simian crease. So it's one fold of hand, one fold of hand. So absence of this fold. So I mean fold of finger. So this first finger. Then congenital heart defects. A lot of congenital heart defects happen there. So we'll discuss these defects later. But they are with these defects, the patient survives. Intestinal stenosis, so that's why a patient can't be fed normally. Umbilical hernia, so not proper development of digestive tract, so in the gut, so gut tube is not folded properly, and that's why umbilical hernia is very common. Predisposition to leukemia happens, and hypotonia. So hypotonia, so these muscles are not well evolved. This is Down syndrome, and this 21st chromosome is very common. And we have trisomy type. So when we have extra 21st chromosome, we have translocation type. So this 21st chromosome is just spread between different chromosomes. And mosaic type. And then in mosaic type, so one cells, so few cells of children, they possess 46, so normal chromosome number, and some cells they have trisomy number of chromosomes. It's because of feature of meiosis. So some cells are undergo some in some cells we have normal chromosome number, in some cells are not. This mosaic type is very common. It's very common, and they survive much better than patients with trisomy, so total trisomy. And maybe you've seen these examples when a 40-year-old Down syndrome patient so can work somewhere, yes, or do some even intellectual work sometimes. So it happens because of actually because it happens usually in mosaic type. So usually patients with Down syndrome, they died in early age, so before the 30 years. So in case of trisomy 21st type or translocation type of disease. Then let's talk about Edwards syndrome. Edwards syndrome, so it's another syndrome. It's of 18 chromosome. Genesis is absolutely similar. We have trisomy type and mosaic type. So also 46 chromosomes, so which changes will be there? Also mental retardation, of course, prominent occipit, but face expression will be different. So it calls micrognathia, so it's absence of okay, just micrognathia, Google it, what is it? Low set ears, so ears will be very close to neck. Short and neck will be very short. Fingers are overlapping, so they are grown together. Then congenital heart defects will be there also, and renal malformations. So a lot of renal changes will be there. And of course limited hip abduction. So these patients will die. So they're not survived too long, because it's much severe lesion than Down syndrome. That's why they survived until first, second year, might be, not more. And then Patau syndrome. So that's it's a 13 chromosome abnormality. So trisomy of 13 chromosome. So first of all, it will be microphthalmia. So eyes are very small, microcephaly, and mental retardation. Of course, so you see every chromosomal disease causes mental retardation. It might cause a polydactyly. So because of genetic genes which are responsible for differentiation of fingers are present in this certain chromosome, it causes the formation of more fingers. Then cardiac defects, renal defects will be there, and rocket bottom feet. So this is rocket bottom feet. So it's also a typical feature of this Patau syndrome and also of Edwards syndrome. So we have deletion syndromes. But okay, don't think that we have no more diseases related to chromosomal abnormalities. So we have diseases, much more diseases, but we don't see the manifestations of the diseases because patient cannot survive with the other trisomies. So because potentially we have so for each chromosome we can have a trisomy or absence of chromosomes, yeah, but they are not survived. They don't survive, and that's why they cannot born, and they usually get aborted, so spontaneously aborted. So 1 minute, okay. Then let's talk about cytogenic disorders involving sex hormones. That's the most interesting, as I think, for me. So we have disorders which are ranging from 45X until 49 XXXXY. So what does it mean? So chromosomes, so sex chromosomes are less aligned. So it's so sometimes I said it's X chromosome is like trial of our it's a trial of our evolution. So sometimes, okay, let's imagine. So by the same process we discussed before, these chromosomes might be lost and might be multiplied. For example, okay, let's talk about Klinefelter syndrome. Klinefelter syndrome. So it's defined as male hypogonadism that develops when there are at least two X chromosomes and one or more Y chromosomes. So the most common type is XXY karyotype. So what we expect from this patient? So what is XXY karyotype? This patient will have so first of all, male gonads will be very poorly developed in this patient. So due to meiotic error, so two X chromosomes is settled in this patient, and that's why this patient will behave like a female. Yeah, so all female patterns will be there. So and it has a it has this deformity, and these patients usually they feel themselves as a gays sometime, and they try to change their personality, yeah, and that's why I blame these persons who blame gays, yeah. So because you see what this person can do with himself. He has more he genetically more female than male. So yes, he has a Y chromosome here, but a lot of so one extra chromosome gives a change to him and his personality to feel like more like female than male, and that's why. So should you blame him for this? I think no. Um, and also a very common mosaic structure. So when the normal chromosome number is cooperated with abnormal chromosome number, and we have in very varied modifications, variations uh, of this structure. It's known as Klinefelter syndrome. Uh, so Klinefelter syndrome is always about male hypogonadism. Then Turner syndrome. Turner syndrome is characterized by primary hypogonadism in phenotypic females resulting from partial or complete monosomy of the short arm of the X chromosome. So you see, it happens when only one X chromosome entered into the baby into the zygote. So you remember that normally, if we have two X chromosomes, so one X chromosome shrinks. But in this case, we have nothing to shrink, and in every cell will be one X chromosome opened, and it means what? So actually, it will be normal female with little changes in. So it has no typical abnormalities. I mean, no abnormalities of somal abnormalities. So here they have only what low posterior hairline, webbing of neck, short stature, coarctation of aorta is the most dangerous condition. So we'll discuss it in heart diseases. Broad chest and widely spaced nipples. So also just nothing specific. Cubitus valgus. Streak ovaries, infertility, amenorrhea. So because of a lack of X chromosomes, so of course they have amenorrhea because of childlike uterus, and even even in teenage. They are she is unable to create a baby. Yes, so they are unable for fertilization because no menstruations happen in this, and they are very common. Pigmented navy, somehow pigmented navy is very common, and so in peripheral lymphedema at birth. So this causes lymphedema in so edema in lower limbs are very common. Okay, so this is Turner syndrome. So okay, we don't stop on this very deep. So but you have to remember. And actually we have so yeah, actually, you may ask me, so why we have XXY XXY disease, and we have XX XY disease? Why don't we have XXX female? Actually, we have. Actually, we have it has no it's sometimes it's known as superwoman phenotype. Superwoman phenotype they have but anyway one only one X chromosome will be active, but it is correlated with formation of the formation of some somatic disorders. These females will be very will be a little retarded. Yeah. Also, but phenotypically they will be, so they have a typical female type of fat deposition. They will be very nice females. Yeah. So that's and they how to say it right. So just imagine all the stereotypes about females, and they are very improved in this female. Will be in this female, with 47 or 48 X chromosomes. And same to XYY. So we have pathology XYY. So it's just imagine all. So now you can imagine all the stereotypes about males. They are very brutal and very expressive. Yes, and then the patients with XYY, so 46 chromosomes XYY, they will have a very increased number of testosterone, and that's why they're very brutal. And usually we can find this people with this chromosomal changes in prison. Yeah, because usually they used to make some crimes, and that's why they usually appeared in prisons. Okay, if I'm not mistaken,
Sir,
that's it.
sir,
Yes.
sir, if female have Y chromosome,
So they cannot.
unfortunately,
If we have Y
then
chromosome, we have SRY gene, and it is male. So female cannot have Y
yeah,
chromosome.
no, sir, if abnormality, sir, if some female have Y chromosome, then the female will have SRY gene. Then the female will be character of
Look,
the
look,
male.
look. Yeah, interesting question. So it usually happens. Look, take a look. When a Y chromosome appeared in a body, it's definition of
Yes.
males. It's its definition of male. So but that it cannot appear. So when female body is formed, yeah. So when female body is formed, and then Y chromosome appears. No, it happens in one cell stage. In one cell stage, that Y chromosome appears inside the cell, and then it is evolved in a male way, and it's only determination of sex, and that's why it's impossible to have Y chromosome in females, of course.
Uh,
Just
okay, sir.
again. Okay, then we have fragile X syndrome. So what is fragile X syndrome? So we'll discuss it in like SAW. So who has no topic for SAW? So please write it down. That's fragile X syndrome. So you will explain it to us in practical class. Okay, what is X fragile X chromosome? So what is ataxia? We discussed. And also, yeah, don't forget about mitochondrial genes. We have Leber hereditary optic neuropathy. So you remember that in mitochondria we have genes, and they're spread only from mother to children, only this transmission. And we have a very restricted amounts of genes in mitochondria. That's why we hear it like Leber hereditary. Yeah, so and only a few examples like Leber hereditary optic neuropathy there. And then this is caused by alterations of imprinted regions. So it is epigenetic process. So when genomic imprinting happens here, so I think we also can I can send it to SAW. So yeah, to SAW. So pediatric diseases will be discussed in pediatric pathology. So that's why it's not to my fate to discuss it with you. So, but chromosomal abnormalities are discussed. So okay, thank you for attention. Next week will be another topic. If you have any questions, you can ask me now. So if there are no questions, now I'll check your attendance, and you can leave. Okay, I checked your attendance, so you can leave. But if you have any questions, you can ask me now. If there are no more questions, thank you for attention. Goodbye.